and just to go back to a basic concept, it's not antibiotics that are required. Our main source of overcoming infections. It's our immune system that overcomes infections. And as we can see there's a balance between the bacteria and the functioning of our immune system. And for the great majority of infections, our immune system will, the balance will be in favour of our immune system. So these are self-limiting infections. And the kind of infections we're talking about tonight are self-limiting infections. And next slide, Rudy. And what happens, antibiotics are not kryptonite, that they don't act all by their own. But what they do is antibiotics can put the finger on the scale, and they can help the immune system in overcoming those bacteria. And that is where that's important, is in infections where either we need the antibiotics to tip the scales, or using antibiotics makes a significant difference to how quickly people get better or how ill they are. And obviously the whole idea of antimicrobial resistance is that if we're using antibiotics when we don't need to, we don't have them to tip those scales when we need to. Thanks, Ruby. So that's painting a pretty grim picture, but things are not entirely grim. There's evidence that that efficient, well-constructed antimicrobial programs for antimicrobial stewardship can reduce the prevalence of antibiotic resistance in the community. So it's not an easy task, but I'll hand it over to Paul to tell us about just what we can do.
Great, thanks very much for that introduction, Parker, and I'll talk a bit about what we can do. But also just to say that by decreasing antibiotic usage, it is at least partially reversible as well. But we need to reduce the antibiotic usage, particularly in the community, by quite a lot to be able to do that. So what I'm going to do is talk about what sorts of things the community and general practice can do to try and reduce the community use. And I say this as someone who was in general practice for about 25 years and who actually struggled to learn how to do this. It's not an easy, straightforward thing to do. Next slide. We could try and just say no to drugs. And in fact, the French ran a campaign on antibiotics are not mandatory as a community campaign, which did help a bit. It slowed the antibiotic usage, but it clearly didn't eliminate community antibiotic usage because it's not quite as simple as that. And as I was saying, it took me years to learn both the sorts of things that Parker's been talking about when antibiotics may or may not be helpful. And then there are, even when you know that they're not helpful in a lot of conditions, there are skills that you need to learn, which we'll talk through. And finally, there are some materials that can be helpful, and I'll talk about all of those, the communication skills, the handouts, and skills like delayed prescribing as well. So next slide. So let's start with the simplest one. Parker mentioned that 1.6 per 100 consultations involves acute bronchitis. Antibiotics are prescribed in 75% of these, and they're needed in almost none. There is some chronic bacterial bronchitis, which is pretty rare, which does need treatment, but almost all the antibiotics that will be seen in practice don't benefit from having antibiotics. The prolonged cough, for example, isn't helped. And markers like yellow phlegm, etc., are not only bad markers, but as Parker was saying, even if it is bacterial, it'll mostly get cleared anyway by your immune system, and the additional gain from antibiotics is trivial. So that's one condition where we could just stop. But for other respiratory conditions, it's a bit more tricky, and that there are some exceptions to this rule. So let's go on to the next slide. The science of stopping antibiotics for acute bronchitis or any condition seems pretty straightforward. It's a pretty persuasive argument for it. But of course, in practice, there's a whole lot of difficulties. Parker's group in Newcastle and others working with general practice registrars, found a lot of factors that make it difficult to cease the unnecessary antibiotic prescribing. Key amongst those is the diagnostic uncertainty. That's not such a problem with bronchitis, but it is with some of the other factors, because you're worried about, for example, a pneumonia or a streptococcal sore throat, etc. Second is the communication problem that I alluded to, that it's just too hard to negotiate the right outcome with the patient, or at least that you haven't practiced that skill enough. And then finally, there's influences of other folk, your peers, but particularly your for GP registrars, it's the supervisor influencing prescribing as well. Next slide. So in general, ERTIs are amongst the easiest diagnostic decisions you'll make all week, but GP registrars and supervisors report that concern about wanting to cover things, because even though most of them will be benign conditions, self-limiting, as Parker said, that you don't need antibiotics for, there's always that background worry that this is something or something that might develop complications. As an example, I used to worry with sore throats that it might be a streptococcal one and they'll develop rheumatic heart disease, or that they could develop a quinsy or some other complication, and so I want to cover things. We don't want bad things to happen when patients, if we get it wrong, and so that's a sort of protective thing, but there are downsides to this too, and so there's always this trade-off, and that's why part of this is learning the difficult skill of doing appropriate prescribing, which Australians could probably lower by roughly 2/3, but you can't get it down to zero. There are some patients that you're going to necessarily need that coverage for, but we can decrease our antibiotic usage a lot. Next slide. Okay, so there are some good resources that supervisors have noted for guidance, and we'll go through some of those. Some problems arise for GP training, the registrar training, and some of it's just the role modelling of non-evidence-based prescribing that they see either in their peers or their supervisor doing. That also importantly sets a precedent for the patient, that it creates expectations for them that if you prescribe antibiotics for a bronchitis, they learn from that bronchitis needs antibiotics. So every time they get it, they come back in, and you're in a vicious cycle then. And it's been shown that you can break that if you can use delayed prescribing that I'll talk about later. You actually decrease the number of patients who come back unnecessarily. And of course, this doesn't apply just to you, but for other doctors within the practice. And so it's useful to agree a policy that's practice-wide. So there have been some interesting studies, for example, of putting up a poster that the practice agrees to, signs and puts up all of their signatures or even pictures and says, this is the practice policy on prescribing antibiotics. That actually signals to the patients, but it also signals to you to each other within the practice that you're taking antibiotic stewardship seriously. So I think it's got those two impacts. It's both, it's like signing your wedding vows, that it's somehow a commitment that you're making amongst yourselves, but it's also being signaled publicly to the patients as well. Next slide. Okay, so the other barrier was it's just too hard to negotiate the right outcome. And the first thing I should say is often we mistake what patients actually expect. People have done studies where they've gotten patients to write down what they were expecting and then asked doctors what they thought the patient was expecting. And doctors are pretty poor at predicting which patients actually did or did not want antibiotics. So part of the skill of this is just finding out what the patient's expectations are. That is the typical thing that's learnt in general practice training is ICE, the ideas, concerns and expectations. And so for antibiotic prescribing, you need to go through that. It doesn't take much time. So you can just ask a simple question about that. But in addition, it's useful to have some materials such as the NPS leaflet or shared decision-making materials, and we'll show you a version of Kate's plots in a moment that go into those shared decision-making materials, and also having methods for doing delayed prescribing. And there are actually several different ways of doing that. So let's look at some of these. Next slide. Written materials. The NPS, unfortunately, is being defunded, but hopefully their fact sheets will be taken over by the Commission. But they've got a lovely fact sheet that you can hand out on what every parent should know about coughs, colds, coughs, earaches, and sore throats. That is very helpful. When I started trying to learn how to de-prescribe and stop prescribing antibiotics in the 1990s, the NPS wasn't around. And I developed my own sheet, and I used to have them pre-printed so that I didn't have to waste time printing them off, and would keep them in my drawer and pull it out. And that, in a sense, gives you the same sense as handing over a prescription, but instead of handing over the prescription, you're handing over a piece of paper, which helps in closing the consultation, but also allows you to talk through some of the things with the fact sheet in front of both of you, the GP and the patient. And this one is written specifically for the Australian context, so it's very helpful. Next slide. Kate's plots, in addition to that material, if you want to get more sophisticated, the next level is to try and do some shared decision making, and that will involve providing some information about the effectiveness or non-effectiveness of antibiotics. And the Kate's plots, invented by a guy called Chris Cates, who's a GP in England, who did a lot of work in his practice to reduce prescribing, developed these plots to show the magnitude of the benefits that might be expected and the so-called number needed to treat. Those concepts can be difficult to explain, so the Kates plots just makes it really visually simple. Next slide. So this is an example of a typical Kates plot about the impact of sore throats of antibiotics on sore throat. And there is some impact. You can see the green faces are the good outcomes. That's, as Parker was saying, these are spontaneously remitting conditions. Most people are going to get better whether or not they have antibiotics. The little yellow faces show those who get better a little earlier because of treatment, and the red is bad outcomes. That is those people who still aren't improved or haven't, whose symptoms haven't stopped after 1 week. Everyone's going to get better eventually, by the way. Very few people will die of a sore throat, very, very few. And that's usually through rheumatic heart disease or something. So this is just what would happen after 1 week. What difference will it make? And you can see that it's fairly small. And the most important fact is that most people are getting better spontaneously anyway, even just by doing nothing. They could get a bit of pain relief by using a non-steroidal anti-inflammatory if they needed that. But the antibiotics only add a little bit to that. Next slide. So things like the Kates plots are incorporated into so-called decision aids. Mina, who's part of the team that's online here, has posted in the chat a link to the decision aids that he helped develop and that have been tested out in general practices and are freely available for download at the Australian Commission on Safety and Quality in Healthcare. So I suggest you click on that link and just have a look at those decision aids, which are for acute bronchitis, otitis media, and sore throat, and have been used by general practitioners. Interestingly, in the trial that Mina did, one of the key improvements that was made was not so much to the patient, but in the GP's knowledge about this, because their expectations were miscalibrated. And by using the decision aids, it helped them to learn more about what the impact of antibiotics was. Next slide. So this shows another version in the decision aids, which shows something very similar to the Kates plots, but shows the possible benefits, both in terms of those Kates plot type diagrams, but also in the number who got better at 3 days. In addition, it shows the possible harms. And one of the things you can see is that actually about the number of people who are getting harmed by antibiotics, who are having adverse effects, is pretty similar in magnitude to the number who are improving symptomatically. So if we're treating with antibiotics purely for symptoms of sore throat, there's no minimal net gain, really. And the only time you really want to consider that is if you're worried about the complications of sore throat, not the symptoms of sore throat. That's particularly important in some groups, and we'll come back to that with some of these exceptions. But for example, in Aboriginal and Torres Strait Islander kids with sore throat who have very high rates of rheumatic heart disease, then I'd be worried about people having them having a strep throat, and would probably be more generous in treating with penicillin. But for most people, it does as much harm as good. Next slide. The final thing I'm going to talk about actually is probably the most impactful thing, because it creates a halfway house for both GP and patient, is the use of delayed prescribing. So what is delayed prescribing? It's not one single thing. You give a patient this prescription that's either filled out or they can pick it up from the desk. Sometimes people have post-dated that, so it's not today's date. Sometimes they date it. Whichever of these that you use, it actually makes a substantial difference to the number of people who then go and get antibiotics. It's about a 50% reduction across the board. It's slightly different with those 3 different ways of doing the delayed prescribing, which is then up to you, and you may use all of them depending upon the nature of the condition and your comfort in learning about it. I would probably suggest the initial way to learn about it is just to give a script dated today and give it to the patient and say, don't take this immediately, only take it if, and then you go through the sort of safety netting processes with them and give them the handout as well. But as you become more comfortable with it, you can probably use other means, but learning that communication skill with them is very important. Next slide. So no difference in clinical outcomes. They've done controlled trials that have compared antibiotics with delayed prescribing, and it makes no difference to the symptoms. And that's not surprising, because for most things, as I said earlier, immediate antibiotics versus no antibiotics don't make a difference to most of the conditions that we see in general practice. It says here 32% of delayed groups actually get the script filled. It varies in the mode that I was talking about, of the mode of delayed prescribing. And interestingly, the satisfaction rates were similar between delayed prescribing and no antibiotic groups. And delayed antibiotics result in the most significant reduction in antibiotic use compared with immediate antibiotics. So it's probably, if I had one skill to recommend to you, it's probably this, though it's helpful to add to your armamentarium things like the handouts as well. Next slide. So on some qualitative work with the GPs and registrars, again done by Parker's group with the GP registrars. Delayed prescribing is used as part of that safety net. It's the thing you're worried about. Particularly, you can imagine you don't know how things are going to develop over the weekend. This may get acutely worse, and so you want to give the antibiotics to the patient, but you've got to walk through the safety netting principles with them. That is, this will generally get better within a couple of days. If it's not going as expected or is getting worse, this is when you can pick up the script. And they more often did it, of course, as I just was alluding to, when it's logistically difficult, like the weekend is coming up or people are in remote locations. And unfortunately, it's probably more used on telehealth as well. But as the red suggests, it's a positive strategy to empower patients about their healthcare. They actually learn from doing this. So one of the things they learn by not using the antibiotics immediately is that they'll get better by themselves. And they also start to learn about the safety netting things, what things to watch out for when they really need antibiotic usage. And so it's a compromise between not prescribing at all and prescribing that helps to meet patients' expectations. I would still want you to go through those expectations, but it's this very helpful intermediate that makes both GP and patient more comfortable and is a stepping stone towards a lesser prescribing. Next. So there are some, I sort of said we're not prescribing antibiotics for most things, but there are some exceptions that, in a sense, test the rule. And I'm going to hand back to Parker to talk about that. But just to remind you, if there are any comments or questions, please post them in the chat because we'll pick up on those in the discussion section shortly.
Thanks, Ruby. Yeah, so there are like all things in medicine, there are exceptions, and it's also important to get those exceptions into context. So certainly immunosuppression will change the balance of those scales we were looking at before. But the important thing is what constitutes relevant immunosuppression. And there's probably some controversy about that and probably some misconceptions as well. So having a diagnosis of diabetes doesn't mean you need an antibiotic every time you get a cold. At the other end of the spectrum, if you have a malignancy and are on chemotherapy and have neutropenia, you need to be really careful, and antibiotics are going to have a much lower threshold there. In between, there's a grade there that can be quite difficult, and I don't think, from my knowledge, there aren't particularly good trial, evidence-based guidelines of what to do there. I've been largely influenced by the opinion of some of my infectious disease colleagues, but again, I think that's something that you may well need some advice around that when you have a tricky area. Then there are serious comorbidities, and this comes into play sometimes, and by far the most frequently for, I think, GPs is with chronic obstructive pulmonary disease, and it's usual practice, and the therapeutic guidelines recommend that you do use antibiotics for patients with an infective exacerbation of COPD when they have increased volume of sputum, fever, and increased purulence of sputum. But really, even there, the antibiotics are only putting a fairly light finger on the scale, and certainly some of our infectious diseases colleagues with patients in hospital won't treat all of them with their exacerbation of COPD, but the ones with more severe infection. The other thing that Paul's already spoken about, because it really is so important, is people who are at risk of non-suppurative complications of streptococcal disease, are at risk of rheumatic fever. So that's especially Aboriginal kids, and especially Aboriginal kids in rural and remote communities, or people who've obviously had rheumatic fever. Young people have had rheumatic fever and have previously had rheumatic heart disease. So yeah, that's, as Paul said, that's the kind of thing as a GP that worries you and lowers your threshold for using antibiotics. Another thing that can be seen in general practice is protracted bacterial bronchitis in kids, usually smallish kids. And it's so common for kids to have ongoing cough, to have a cough going 4 weeks, because they have a post-infective cough. They run so many colds together. It's not uncommon for kids to have a prolonged cough. But if it's a protracted cough, a wet cough going for longer than 4 weeks, then a concern there that there is a level of bacterial infection there with the bronchitis, and it's been shown that a course of antibiotics longer than a usual course of antibiotics does improve that. So, like with anything, there's exceptions that you have to be careful of as a practitioner, but the strong message remains that you look positively at identifying these rather than having diagnostic uncertainty driving inappropriately high prescribing of antibiotics. So thanks, Ruby. And Paul was going to talk about this really handy summary of the therapeutic guidelines.
Yep, thanks, Parker. So this is a lovely 2-page summary of when you should use and what antibiotic you should use in various conditions. It's free to download from the therapeutic guidelines, even if you don't subscribe to therapeutic guidelines. So I highly recommend it. You need to know about what the conditions are. That's usually in the notes or in that first line therapy. You can see it says, for example, with the tonsillitis, patients not at high risk of acute rheumatic fever, as Parker was saying, symptomatic treatment in most cases. But if they're at high risk, those Indigenous kids, then phenoxymethylpenicillin, etc. So it's a very useful summary. That's part of the knowledge base that you need, as well as those skills and handouts. So I'd highly recommend downloading that for free and having a little study of that.
So thank you so much, Paul and Parker, for that really insightful presentation. So I'm going to call the rest of the panel, Kirsty and Joanne as well. And I'm just wondering if I should stop sharing. I want to stop sharing so we can see most of us online. So are there any questions from the audience? I'll give you 10 seconds to think. If you want to, you can always put it in chat. And also, if you want to, just raise your hand and we will ask you questions. I mean, we'll ask you to ask the questions, but turn the camera on if you want to talk to us. So are there any questions for the panel? Fiona, I'm going to ask you to unmute.
I can unmute.
And
Excellent.
Can we see your face, Fiona?
Oh, yes, you can see my face. Am I there? Yes.
Yes, you are.
Hello. So thank you very much for that presentation. And I'm a researcher, a nurse researcher at the NCAS. And I guess my question is really around, because you spoke, Paul, about bringing, the influence of supervisors on GP registrars, for example, on their prescribing practice. But when you also spoke about bringing everyone in the practice, and I have to confess I'm not a GP nurse, I'm a practice nurse. But I think a lot about how nurses can contribute to this big AMR effort, if you like. That's the focus of my research. And I guess what I'm wondering is what the panel thinks about how practice nurses can be brought into the picture, because they could really influence certainly consumer expectations and perhaps even opening up that discussion that may then be followed up with the GP.
So I'll start with Paul first.
It's a very good question, and I don't have a straightforward answer to it, so I'm going to give an indirect one. And that's that one of the things we've been looking at here is the role of pharmacists in antibiotic prescribing. And the reason for that is that we've discovered that because of a pharmacist who works with us, that pharmacists quite often recommend that patients go to GPs to get antibiotics, but the patients never say that to the general practitioner. So GPs are completely unaware of the fact that pharmacists are sending them patients. So it's an area that we're thinking needs further study to educate pharmacists about when it's appropriate and to get the patients perhaps, and for GPs to even inquire about why they came along. That was the pharmacist that sent you. I am not aware of any similar research with practice nurses, but particularly if practice nurses do triage, then setting their the patient's expectations about whether they might need an antibiotic or not might be equally important. But I don't actually know, because I don't know any research on that.
So before we go to Parker, I'm going to ask Joanne first, if that's okay, Parker. So Joanne, have you got anything to add to this?
I think that obviously general practice nurses are a really key member of the general practice team. And often they have developed specific skill sets in things like wound care, diabetes and the like. And as a result, I think that they do have an important role to play. People with chronic wounds, we know that they often get antibiotics prescribed, which are not actually going to make any difference to those wounds. And so upskilling practice nurses to also be able to question GPs or give their opinion. I know that they're not the prescriber, but they're an important member of the healthcare team. And if they have something, concerns, then they should be able to talk to them, and also to reinforce things that other people in the team are saying. because we know that practice nurses are very trusted. They often have longitudinal relationships with patients. And so having people that are able to reinforce the same message is going to be really, really important.
Thank you, Joanne. Parker?
Yeah, I think that example of wound care is a good one, because certainly I've worked in practices where chronic wound care has been nurse-led, and certainly upskilling there would be useful. I think the other thing is, if you are taking a whole of practice coordinated approach to antimicrobial stewardship, the nurse is part of that, and the nurses have probably opportunities there, especially with immunisations and especially immunisation of kids, where a lot of our prescribing is because no one wants to miss an infection in a child. So I think there's considerable scope there, but I haven't seen it in the past or read about it.
So thanks, Parker. In fact, this leads nicely to Brenda's question. So Brenda, thank you for coming and asking questions. You want to take yourself off mute and show us your face and ask the question that you have posted in chat. Okay, maybe not. So I asked the question, and I'm going to ask Kirsty to answer the this question first. So Brenda said, we've been hearing a few people say that there are concerns about an increase in sepsis in children if antibiotics are delayed. So how do you think we can address these concerns? And would you say delayed prescribing is the only way?
Hi, Ruby. Thanks. So I should start with a disclosure to say I'm not a paediatric doctor, so I don't really have a lot of credibility in talking about this, but I can speak in general. And I do acknowledge, Brenda, I've heard the same significant concerns, and I think we've all seen some cases in the media and things that make us quite worried. I think it probably segues quite nicely with the discussion around nurses, and I think what it's speaking to is this idea of us as healthcare providers acting as educators for the community and setting expectations for what is normal and when is something an alarming sign. So that concept of Paul spoke to safety netting, and really, I guess, trying to help teach people about what is a normal febrile kid with a sore throat, and when is this kid sick enough that we need to be thinking about getting them to hospital, and I guess helping people set a plan for what they're going to do, what they're looking for and what they're going to do. And certainly once kids are geting sick enough that we're all worried that this could be sepsis, delay is something we do want to avoid. Delayed prescribing comes after a clinical assessment by a good GP who said there's nothing here that makes me worried that this person has sepsis, and I think this is bronchitis or pharyngitis or something. So that would be my comments around this, I think, but happy to hear from others.
I muted myself because the dogs are barking. I think then we'll go back the other way. We'll ask Parker first. So have you got anything to add to that?
Yeah, just I think that the number of kids who present with sepsis is small overall, and if we're trying to use antibiotics frequently to prevent that, that's not rational itself. And you have to think also about kids how much will some oral antibiotics help in that situation anyway. And I think the important thing is to have clear rules and clear safety netting about the kind of symptoms that the things, and it's mainly applying to kids, that the parents will see in their kids. What kind of things do you need to have them assessed again? I think that's the rational way to approach that, rather than saying we can prevent it.
Joanne?
Yeah, it's a really interesting one. It's really different when you've got that person in front of you. But I think that there's a couple of different things that we can look to the research on this. So I know that there's been a study, and it was in the United Kingdom, so maybe a little bit different to our population, where they were able to have a look at a lot of general practice data, and they were able to compare general practices that were high prescribers of antibiotics and compare that to practices that were low prescribers. And they actually didn't see any significant differences in outcomes between those low and high prescribing practices. So to me, that's pretty reassuring. The other thing is we have to always remember the harms. Now, if a kid gets has sepsis, then of course that's a horrible thing to happen, and we never want it to happen. But we also can see other harms like antibiotic resistance that lasts for like more than a year after that child is exposed to antibiotics, increasing their risk that if they actually do need them in the future. There's ongoing research about the impact on the microbiome, and there's kids that are allergic that have their first episode of allergy or anaphylaxis to antibiotics. So we can't think that, I mean, antibiotics, we're so lucky to have them, but we can't think that they're also harmless medicines, because like any medicine, they can have side effects.
Oh,
Yeah, so I agree with everything everyone said. I'll just add that the biggest problem group is the very young child. You know, so we're sort of talking under 6 months, and because they're pre-verbal, it's just hard. You can't get as accurate a history. It's more like veterinary medicine. And so the degree of uncertainty that we were talking about as a problem is just increased in the very young kids. It's not as great a problem with the older kids. And as Joanne was saying, in countries that have lowered their antibiotic prescribing rates carefully over time, and people have learned how to manage this uncertainty and processes, they don't see a difference in the rates. So for example, in Sweden had the same antibiotic prescribing rates as us in the 1990s. They now have an antibiotic prescribing rate that's about a third of ours in primary care. And they've been monitoring the number of people with all people with complications such as mastoiditis, sepsis, etc. And that hasn't changed over time. But that's because they've come down slowly. It's been a sort of learning process. This isn't something you want to start doing, dropping your rate 70% tomorrow. You've got to learn how to do it slowly with those sort of skills that I was talking about.
Kirsty.
I was just reflecting as I was hearing the discussion, and maybe it would be very rare that you see a kid who's febrile but is playing in the waiting room and is quite active, and you're worried that this could be sepsis, you know. So I think there's much more than just a fever that makes you worried about sepsis, and perhaps what we should be talking a lot more about is educating both the community, importantly, because we want people in the community to recognise sepsis and present to medical attention. But the work that I do, I work in a hospital, so I'm talking a lot to junior doctors who might be down in the emergency department and things, and helping them to recognise sepsis. So thinking about those things like the very acute onset where somebody gets sick very quickly, you know, they're presenting to care in sort of 24 hours. They've got a rigor, they've got muscle aches, they might be confused. If it's a kid, they're listless and they're not playing and they're floppy. And we talk about pale and cold hands, they're shut down, you know. So there's lots of things that vomiting and sometimes a headache is a false localizing sign. They're all things, they're the kids, or in my practice, the adults or adolescents, where we're really asking, boy, oh boy, this could be sepsis and I need to get going quickly. So I don't mean to be telling you all how to suck eggs, because I know you all practice as clinicians all the time, but the vast majority of the people that you're seeing don't look like that. And so it's usually not the question, could I be, is this sepsis and am I doing the wrong thing?
Thanks, Kirsty, and thank you to the panel. I've only really got 2 minutes, but, if we want to have a break. But I actually do want to ask you guys about something totally different. It's around telehealth and prescribing. So it's been very interesting, especially in the last 2-3 years where COVID restriction, then GPs are starting to see their patient via telehealth. Do you think they actually have an effect to antibiotic prescribing? I'd like to start with Paul first.
Right, we should actually ask Mina this question. He's done a systematic review of the observational studies looking at the impact of telehealth on prescribing. They're all observational, they're confounded, and so it's and they haven't been adjusted for correctly for the differences in the populations of people who attend for telehealth versus face-to-face. So it's very hard to tell, but the suggestion in those studies was that telehealth increases antibiotic prescribing, as you might imagine, because you've got increased diagnostic uncertainty because of your limited ability to examine the patient. And so that probably increases your sense of uncertainty compared with having the patient in your room, being able to examine them. As Kirsty was saying, you can see them playing, etc. And particularly if it's a telephone rather than a video consultation, your signal, your diagnostic signal is even further reduced, and so your uncertainty is greater. So I think it is a problem for telehealth and increased antibiotic usage. But it's something that needs further research on how we can. I think it's a real phenomena, but we then also need to know if telehealth isn't going away, how can we reduce the problem?
Parker.
Well, we certainly dealt with this problem with talking to registrars in a session that Paul and I have done with New South Wales and ACT registrars. And it's difficult to help them when it's a new phenomenon. We're not quite sure, but I think we really did talk around doing the best you can with the resources you've got by telehealth, and you can do some examination if you limited examination if you use video rather than telephone. But I think the real thing that we're talking about there is that we didn't want the uncertainty of telehealth to then make the default antibiotics, that to use it to use other ways to really go that extra yard in your safety netting with the patient, and also and having a fairly low threshold for saying I really need to see this patient face to face. Now I know in some circumstances that's not been as easy as always easy in recent circumstances, but I think those were the principles we came up with. Do the best with what you've got, but then have really, really meticulous safety netting, and just have a low threshold for bailing out and saying, no, I'm not going to be happy until I see this patient.
Joanne, have you got anything to add to that?
No, not really, Ruby. I think the only thing that I would add, just to close off some of the telehealth discussion, is more from a clinical perspective than a research perspective. And I think what we're seeing at the moment is a proliferation of things like InstaScripts and things like that are actually fragmenting care. So you've got people that are having to make decisions about care that don't have a long-standing relationship with the patient or understand the medical history and the like. So I think the key thing for us as a primary care general practice community is to think about how can we offer convenient services to people that do feel unwell and that are stressed, so that they come back to a home base with people that they know, and hence are more likely to get appropriate prescribing if they need it. And I guess the other part of that is, as was mentioned before, it's really hard to see in a kid's ear via telehealth. And, there are some smart whiz-bang things that are being developed for people to have, special cameras on their phones. But a lot of people aren't going to invest in them quite reasonably. And so there always does need to be some kind of backup plan available, that if you do need to examine somebody because you're worried about them, or you need to see if they really do have an infection, that you have those backup services available where somebody can have a physical examination if they require it. And I don't think we've necessarily got that sorted out for all of the different platforms that are emerging. And so anyway, Paul and Mina, that's another one for you down the track to explore, because I think that is going to be an increasing issue that we see.
Look, I want to thank the panel for the incredible insight that you've given and the questions from the audience as well. So what I want to do now is give you guys a 5-minute break. So we will reconvene back here at 7:05. And we'll see you soon. Together, and he'll send you in, so send you and allocate you to a breakout room. So in the breakout room, we're going to have a panel of speakers to lead the questions. So we're going to be talking around things like, what are your antimicrobial stewardship priorities, and what would a antibiotic stewardship program look like? And in your practice and organisational setting, what would motivate you and your practice organisation to implement a AMS program? And what resources do you think would help you and your patients around AMS? I'm also very conscious that there are policymakers in the mix of this attendees in the mix of this group, which is a great thing, because for those that are not in general practice or actually in policies, you can actually talk about and discuss what do you think you need to do to assist and encourage general practice or community to implement a AMS program, and what can you do to help. So please, when you get into the group, nominate a scribe and a spokesperson, and then in about 25 minutes or so, 30 minutes, we'll actually bring you back into the main group, and we'll discuss what you guys have been talking about. So Mina, would you mind sending everyone to their breakout rooms, please?
Oh, just a couple of minutes. Sure, sorry.
Yeah. So welcome back, everyone. I hope that was a pretty good and good discussion. That you get to know the people that are in your group, as well as talking about what it really looks like. So I want to start with group 1. That's Paul's group. So does Paul want to nominate someone in your group?
So Ruby, I think Paul nominated me to report back. So I'm
All
happy
right, yeah.
to report back. Okay, so all of us were from different backgrounds. Some of us had done some qualitative research with general practitioners about antimicrobial use and antimicrobial stewardship. So we discussed some of the insights that we've gained from that research and that experience. But generally what we said, what we talked about was the practice level, I guess, some of the institutional barriers and enablers, which we don't know from our research, our qualitative research with individual practitioners, individual prescribers speaking as individual in their individual capacity, rather than reflecting institutional viewpoints or perspectives from, I guess, practice as such. So so one of the things we discussed was we don't have much research about what may be happening at the practice level in the general practice setting. So thinking about the clinic structure, thinking about governance, thinking about accreditation programs, thinking about the incentive, the time, the resources, and those factors. We don't have much information from just the research that we've read about or we've done with individuals. So that was one. However, we also had, one of our participants has had a lot of experience leading AMS programs or leading the sort of AMS awareness in hospitals, or small hospitals in regional areas in Australia, but also internationally now. So hospitals that may be resource poor. So, they shared perspectives on the importance of leadership and having a change champion, someone who can champion AMS or AMS awareness in these settings, and that it has been successful in the hospital setting and in the international sort of resource poor setting as well, where change champions and sort of leaders have been able to push the message along. And finally, we did have a bit of a conversation about the importance of incentives that in general practice, which is a setting where you have a lot of dispersed, institutions and clinics, where it's very difficult to have a consolidated institutional response to a particular issue, that it would be important to have incentives so that, sector-wide, you have participation in a particular initiative and you have uptake of that initiative. So what those incentives might be, whether they are accreditation-related incentives or financial incentives, that it would be interesting to explore from a policy perspective. So yeah, I think that's a summary of what we discussed.
Thank you very much, Arjun. That's actually very useful and valuable summary. So I'll ask group 2, which is Parker's group. So have you got someone that you've nominated, Parker?
Lucas has volunteered to bring some of our ideas to the group. Lucas?
Yeah, thank you, Parker. We talked a bit about like making a situational diagnostic about how's the antibiotic prescriptions are going on in our services. That way we could like aim for like the most objective way to reduce and to see if we have like an increased antibiotic prescribing and which conditions this is happening. So in that case we can train the team and hear the difficulties that the other professionals have regarding this issue, and to have a guideline approach situation, like where you can train the rest of your team. We have in our group we have different backgrounds as well. We had like one nurse that used to work in ICU and one pharmacist. So there was some issues like regarding the role of exams as well and specimens collection and the usage of the right antibiotic, right dosage, this deep prescription as well. For that case, like an optimal usage of antibiotics.
Fantastic. That's really great. All right, the third group, which is Joanne's group.
Yes, so I'm going to hand over to Leslie, who's going to represent our team.
Thanks, Joanne. Yes, I was the scribe. I've just been trying to sort out all the notes. So priorities. Well, we had a diverse group. We were all different backgrounds. One person did work with an Aboriginal population in a more remote area and said, but I think this is also probably applicable to other areas too, that you've got a population that has lots of infections, may have very poor health literacy. They need antibiotics. But conveying the information is a problem. So you're needing community education and you also need prevention and you need culturally appropriate resources is a priority for that sort of population. Other priorities were things like the duration of antibiotics can be too long, also too long between reviews. Sometimes the diagnosis can be doubtful, that you need assistance with undifferentiated illnesses as well. Priorities, it's therapeutic guidelines is a great resource, and it was shocking that GPs don't get access. Government priorities and funding are also priorities. Pack sizes that match therapeutic guidelines. And a big priority was no nationally coordinated antimicrobial stewardship program, and yet most antibiotics are prescribed in general practice. Big mismatch there. The program, what it might look like, ideally you need a key team members of pharmacists, nurses, but you don't necessarily have those in GP. So then it was mentioned about having perhaps a hub and spoke model for support with perhaps a paid pharmacist as well, professionally led, which perhaps goes back to some of the money we need. We need the funding for the pharmacist. This is perhaps going into resourcing as well. We need data and good data management, benchmarking, so that you can compare yourself, your practice with your area, your state and national. And GPs don't respond well to volume-based feedback. It needs to be about appropriateness. And then the list of resources, of course, came from all of that, that GPs need active clinical decision support. They need therapeutic guidelines. They need access to pharmacists. They need a nationally coordinated AMS program. They need culturally appropriate resources and health literacy programs. And that was about as much as we had time for before we got booted out. Has that covered everything, Joanne, do you think, that we discussed? We did a lot. Well done.
Well done, guys. That was a lot of topics that you've actually discussed and talked about. So finally, group for Kirsty.
Hi, Ruby. So I'm actually speaking for the group because other members weren't in a position where they could take notes at the time. So we started off talking about some priorities being centred around patient education, exploring beliefs and attitudes, and empowering people to manage without antibiotics. But the discussion sort of segued into really, we had an experienced GP in our group who was talking about a lot of trust building, so knowing a patient well and giving them access to you for an early review. So saying, look, I don't think you need antibiotics, you can go home, but I'll give you a call at the end of the day, or I'll give you a call tomorrow and just touch base and see how the child is going. And that builds confidence. And that was a way that this particular GP was sort of, I guess, educating patients not to expect antibiotics. And he spoke about, that being particularly important with first-time parents, and that confidence grows and it's not needed so much for a second-time parent. We spoke about cultural pressures and particular cultural groups having expectations for antibiotics, and there needing to be some attention specifically around those groups. In terms of resources, there was certainly awareness and people were using things like ETG, or in Victoria, the Royal Children's Hospital guidelines were mentioned, and paediatric health pathways. They spoke about trusting resources if they came from the College of GPs or from ACRIM, or from the local hospital. So if it was badged from a recognised local source. There was some discussion toward the end about using the primary healthcare networks as well. And finally, we spoke about where consumers were currently going for their education. And there was some talk about use of Instagram and medical influencers, some of whom were nurses and GPs themselves who had got education down to bite-sized pieces, and maybe there was something we could learn from them in customising the information that we might be providing from more reputable sources. So it was a really fruitful discussion and lots of good ideas. So thank you to the group I was with.
Wow, that's a lot of writing. I've just put down 2 pages of your summary. So what I'm actually hearing is that, first thing, I think Mina did a fantastic job putting the groups together and making sure there's a diverse group. So, there may be a GP here and definitely a pharmacist there and some policymakers there. So actually had a really great conversation by the sounds of it. The other thing that I'm getting out of this is that it's great to put the responsibilities in for a GP to say, you know, you got to prescribe. It's not about volume, but you got to prescribe appropriately. However, it's really about the cultural aspect. It's really dependent also on the patient, whether they're asking or whether they even understand, you know, whether they should or shouldn't take antibiotics, and also the GP's perception. But it's also around the practice culture, but it may even be bigger than that in terms of, you know, the organisation, the government. So if we can have enough resources to the general practice in primary care, which someone actually said, you know, primary care is actually the huge volume of antibiotic prescribed. This is where we really need to help them and enforce the message to them and the patients that antibiotic may not be necessary, may not actually help, and it could harm the patient themselves. There are good strategies such as pack sizes we're talking about, and also providing great resources to general practice as well as also the patients themselves. The other thing that I took away was an AMS champion. So this is really, really important to have an AMS champion. So I know Kirsty will probably say in the hospital, we would have a AMS pharmacist who can actually help do a lot of these, you know, audits and feedback around prescribing, appropriate prescribing. We don't see that in general practice. We actually don't have the champion, the practice champions that could help general practitioners to do this amount of work. So maybe it's really about that. And the other thing I also heard about is incentive for the GP or the general practice to do a lot of these AMS work. So maybe even the pay pharmacist. So resources, we can talk about any guidelines, resources, as well as, you know, therapeutic guidelines, and then we can actually get, well, hopefully get help from primary health network and so forth. That's actually some of my take-home messages that I'm trying to process while I'm listening to you guys. Are there any questions from the audience that we want to have we want to talk about or discuss, and also ask our panel members who are still here? Is there anything that, I mean, I'm sure Leslie's got a few things that she hasn't quite finished discussing that she may want to bring up as well. So are there any questions?
Can I just say, in our group, there was a little bit of a discussion about champions. I'd actually mentioned champions, but it was pointed out that GPs have to know hundreds of conditions and so on, and that perhaps, you know, you can't have a champion for them all. And it goes back to that funding model where you need that pharmacist coming in, perhaps, as instead of having a champion within the practice, you have that something like that hub and spoke model, where you've got a paid pharmacist who can come in and help run that program. So I think that certainly has got more merit rather than just putting another load on another poor GP or a nurse.
So I'm going back to the panel then. I'm going to start with Paul. So do you think having a practice champion, whatever role that champion is, whether it's a pharmacist or nurse, how do you see that helping general practice?
So I think the key thing that came up in our group is it's not, champion is probably the wrong word, but you have to persuade the leadership of the practice. And sometimes that's an individual, sometimes it's a couple of people within a practice, that having an AMS program is a good idea. And that's the key component of it. Once they think it's a good idea, yes, you could then have somebody else who assists with that, like bringing in a pharmacist to help assist the program. But you've got the gatekeeper problem that the leadership of the practice has to actually open the door to that AMS program. And without the change in incentive structures, which, as Aryan said, could be either the accreditation requirements or it could be a financial incentive, it would be hard to get the worst practices, the one that needs AMS most, on side to do an AMS program. So I'd see that as the key barrier. And my feeling is that in research and policy wise, we've neglected that. NPS and us researchers have focused on the individual practitioner, not the practice. Both are important, but I think that's the big yearning gap for me, is working out what we can do to better engage whole practices in doing something about it.
Joanne?
Yeah, great conversation. So as part of some of the RACGP funded research that we've done, we have done some practice level intervention using data extracted from electronic medical records and feeding that back to practices and linking it to continuing professional development points. And the practices, despite it being during the COVID, in the thick of COVID, did appreciate that, because they didn't actually have to do any of the work. We extracted the data, we analysed the data, we fed it back to them, and all they had to do was come to a feedback session where they could ask questions about things that were important to them. The challenge that we've got is how we move the dial from a policy perspective, and how we continue to develop these systems so that it's a scalable system. I think that we've moved a little bit beyond having a champion and having, people visiting individual general practices, because we know that system is already not working. And all it's doing is providing extra barriers and expense, when we really need to look at how we can do things in a smarter way. It's fantastic that we've got some research grants to look at this, but what we really need is to get smarter in other ways. And I'd say that's in political lobbying in this area, to get some funding for an ongoing program for antimicrobial stewardship in general practice. Otherwise, we'll keep on doing pilots that are great. We'll keep on, having programs that occur every 3 years that have an amazing impact, but then are forgotten because they, never happen again. And so we have to get smarter about how we can do a lot of the heavy lifting for the practices.
Thanks, Joanne. Parker?
But one thing that was raised in our group was the idea of having outreach from the teams that already do antimicrobial stewardship within hospitals, etc. That could there be a level of expertise there that could advise practices and help practices both in what they need to set up, and also some kind of monitoring feedback system about how the practices are going. So that was one idea that was raised by our guys.
Okay, Kirsty, was there anything you want to add from your group?
No, I mean, I'm listening and reflecting on what's been said and agree. I think anything that we do, as much of it that can be passive or fitting within usual workflow, is ideal, rather than something that's added on. And I think if we can leverage any other quality and safety activities that are happening in general practice, so that it's not seen as something separate and standalone, but if we can integrate it in a way such that, it's a cultural commitment to improvement as a practice, as Paul was saying, and whether it applies to antibiotics or opiates or whatever it is, that we collectively work together to reflect on what we're doing, and to look at the evidence and progress and improve. So that would be the framework that I'd be looking for. And try to steer clear of anything that's too targeted and reliant on an individual,
Yeah. Thanks, Kirsty. I see that Cass has joined us, and for those who don't know who Cass is, she is the director of the National Centre Antimicrobial Stewardship. Cass, are you there? Did you want to say hi to the group? No.
Hello, everyone. It's a really great discussion, and I agree with many of the points. And I think that building out their digital infrastructure to support GPs but getting the information back to them in a timely way, I think is a real challenge. And I just, in the chat, I popped the work in that Sajal Sahar did, where he did national surveys. Some of you might have been involved, actually, national surveys of GPs and community pharmacists, because obviously the community pharmacists are a key player here, but I don't have a strong sense of how they're currently engaged. And I guess this is a piece of work that we're really keen to explore, and I'm interested to hear your thoughts about that, because that's another piece of the puzzle that I don't think we've really thought about. I like the idea of that hub and spoke, and in fact there's been a number of really effective GP trials. For example, Harriet Hiscock did one with the paediatricians coming into the general practices to support them with decision making about sick children, and maybe that hub and spoke model for stewardship pharmacists might be a really nice way as well.
Thanks, Cass. Does any of the GPs here want to respond to that? Joanne.
I guess a key thing to start off with is I know that there's a lot of discussion at the moment around our pharmacies prescribing and dispensing antibiotics, but I think if we can cut through some of that noise, there's already really great examples of collaboration between community pharmacists and GPs. And certainly I would like to think that is something that we can continue doing and probably formalise a little bit more in some ways. I think would have value as much. You will never get a GP complaining if a pharmacist rings them and says, just letting you know that this is, not the appropriate, dose of an antibiotic for a child to have for their ear infection, so that you can have a conversation about that. I think that we need to be very mindful in anything that we set up about fragmentation of care. The ability, as I mentioned before, to have backup mechanisms to make sure that people that need appropriate examinations can have them, and also recognise that there are areas where access to health professionals is difficult, and we do need to have safety netting available for those people. So I think one of our challenges is that we don't have good antimicrobial stewardship programs in general practice where the most antibiotics are prescribed. And if we can't manage that, how are we going to look at expanding that to community pharmacy in the short term, where there's been no funding coming from our government for a really long time? So I think there's lots of challenges to be worked through here from a policy perspective and a funding perspective. There's no magic bullets, but I think that remaining mindful that pharmacists and GPs do work on the whole really well together and not losing that. I think that there's a lot of value. And I think that what we could do a little bit better, and I think it's been a great example tonight, is people from lots of different disciplines coming together and learning from each other's perspectives. And I think that there's ways that we could do that, to have community pharmacists and GPs being able to learn together in a better way than what we have currently, which is very minimal.
So Joanne has just done a fantastic job of my closing remarks, which I'll let her since I report to her. So I'm just wanting to say thank you so much, everyone, for joining this session. And I know some of, there's a few that have popped off already. It is close to 8 o'clock. But I just want to remind the group, if you haven't already, there are 2 more sessions of the Antimicrobial Awareness Week 2020. There's 2 more workshops tomorrow. One is the antimicrobial stewardship in the okay, it is 8 o'clock and I'm getting tired in the immunocompromised patient that Cass Thursky will be chairing tomorrow. It's also the priorities for antimicrobial stewardship in aged care. So for those who are interested in aged care, Associate Professor Nolene Bennett will be the one that's going to be leading the group. So as usual, go and just scan in and register the QR code, and also check out the NCAS website, which is on the website down here. And just want to thank the panel so much for leading the workshop today, and also want to thank Mina and Courtney for helping me, and of course thank you to all the participants who joined this session. So we'll see you hopefully next year at the next Antimicrobial Stewardship Antimicrobial Awareness Week. So thank you.
Thank you, Ruby.